So our next speaker is Professor Tsao from University of Tennessee. And I will leave you the floor now.
Thank you very much for inviting me, Max, to come to this conference. So we'll talk a little bit this afternoon about the history of phantom limb pain, as well as some of the more modern day theories building upon what Professor Cervera just talked about. So we'll talk a little bit more in depth about some of the theories of phantom pain. We've been focusing on mirror therapy as a treatment, and we'll talk about sort of how we've built upon that over the last few years. So as already defined, what phantom pain is. It's the sensation that the amputated limb is still present, so that's phantom sensations. And oftentimes people are reporting that their limb is stuck in an uncomfortable position, or it has other sensory phenomena associated with it, or it feels like it's shortened, a term called telescoping. Review of the literature suggests that up to 95% of adults have phantom pain or phantom sensations after an amputation, and then over time, the limb may fade from memory, so people will no longer remember that they ever had a hand or a foot. Generally, pharmacological treatments have been ineffective. We've built upon our work based upon military amputees from Iraq and Afghanistan. I was active duty in the United States Navy during the buildup in Iraq and Afghanistan, and so we unfortunately had a lot of amputees coming into our hospital at Walter Reed. And so we became more interested as a group in terms of how to treat it, because we had soldiers and other military service members on high doses of opioids, and it wasn't touching their phantom limb pain. So historically, I'm not going to go back over everything that was just said, but phantom pain doesn't always happen just because of trauma. Sort of you have elective surgeries, you may lose a limb due to diabetes or cancer, and you can also have phantom pain there. It turns out that it's not only large limbs, though people think about that because that's one of the most visible amputations, but even digits, people will have phantom sensation or phantom pain if they lose a finger. And then it's been reported phantom sensations after hysterectomy or mastectomy also. Originally, it was thought to have a psychiatric etiology, but as hopefully by the end of my talk, you'll think that it has a neurological basis as well. And the focus originally was on surgical neuroma. So as talked about in the last lecture, Ambrose Paré was the first to really characterize it. He wrote that patients imagine that they have their members yet entire, yet do complain thereof a pain like to convulsions. And the key word here is convulsion. So the typical patient who you talk to will describe their phantom pain lasting about, seconds to minutes. And so that's typically, when you think about that as a neurologist, we think about seizures. And so the seizure lasts about 90 seconds. So in some ways, there's similarity between phantom pain episodes and seizures. Descartes, the French philosophy, was the first person to actually theorize that there could be a cortical or brain origin of the phantom limb pain. And it was well known enough in literature, that in American literature, that Captain Ahab, the fictional captain of this whaling boat, talks about it in Moby Dick. He says, "I still feel the smart of my crushed leg, though it be now so long dissolved." And then perhaps the best characterization was Silas Weir Mitchell. He was a Civil War surgeon for the Union in the States. And he wrote about it because they were doing a lot of battlefield amputations. He wrote about it under a pseudonym and sort of talked about this in a story form in the Atlantic magazine. And so I pulled out two of the main passages or paragraphs from that. And so he wrote that, "I found that the great mass of men who had undergone amputations for many months felt the unusual consciousness that they still had the lost limb. It itched or pained or was cramped, but never felt hot or cold. If they had painful sensations referred to it, the conviction of its existence continued unaltered for long periods, but where no pain was felt in it, then by degrees the sense of having that limb faded away entirely." He also gave the first description of telescoping. Another set of cases present a peculiarity which I am at a loss to account for. Where the leg, for instance, has been lost, they feel as if the foot was present, but as though the leg were shortened. If the thigh has been taken off, there seems to them to be a foot at the knee. If the arm, a hand seems to be at the elbow or attached to the stump itself. So these are very clear descriptions of what was going on. So I'll give a couple patient examples of people who I saw. The first was a 24-year-old Marine. He lost his right hand during a gun battle. He actually described his pain as his finger was stuck in the firing position of his rifle and it was accompanied by cramping in the hand muscle. So it wasn't a vague pain. It was a very clear description of what he was feeling. And interestingly enough, it was the entire gamut of sensations. It was like he couldn't release it. By the time he came to see me, he said the pain had faded after 6 weeks, and he no longer remembered that he even had a hand. The second is a 20-year-old soldier. He lost his right foot. He described his toes were curled in, the foot was stuck in a frozen position, and then he also said, you know, some of these patients, he felt like he's wearing a boot that was one size too small. So why does phantom pain occur? So nobody really knows what the etiology is. We do know that it can often start immediately after amputation. So somebody wakes up from their surgery and they have phantom limb pain. But the classical theory is sort of neuroplasticity or reorganization or new cortical connections being made. The second is sort of that there's maybe a mismatch in signaling between vision and proprioception, and the third is proprioceptive memory. So the first theory goes that, you know, the neurons that used to control movement of the hand or the foot are no longer active, and so they start making connections to neurons in the nearby regions of the brain. That has a lot of data that supports it. The second is that there's this mismatch in terms of movements, in terms of vision and proprioception. So as I'm pushing the clicker to advance the slides, I'm sort of feeling where the clicker is from my fingers, but then I'll look down every so often to make sure I'm pushing the forward button, not the reverse button. And so with all movements, you have both components of vision and proprioception, vision being the more important thing. And so the thinking is, well, you take away the limb, now vision is telling the brain one thing, but the feedback from the periphery is telling the brain something else. And so the only way the brain makes sense of it is it's creating this phantom limb. And then the last thing is sort of this whole idea of proprioceptive memory, which is when the limb exists, all these other things that were going on with the limb are also pulled in terms of memory engrams. So like the guy who was firing the rifle, right? He had sort of the whole cramping sensation. So the cortical reorganization theory was based upon work in animals by Pons, Koss, Merchanus, and Wall. And I'll apologize up front, I'm not going to touch the work of everybody who's done great work over the years defining this issue. So they looked at non-human primates, and so they took off a digit. And what they found in this particular case was, so this is the monkey, so if they took off the middle digit, what they found later on over time is that the regions of the two side digits in the brain actually took over that region. So that's the whole idea of neuroplasticity or remodeling over time. And then when applied to humans, so we look at the Penfield homunculus, so Weir Penfield was a neurosurgeon. He really mapped out the brain, and so sensory is on the left, motor is on the right. And you can see there's a large amount of motor territory, that controls the hand and the face, and less so sort of things that control the legs. And so Ramachandran, building upon that work, thought that there should be human correlates of the animal findings of neuroplasticity. And so he looked at what happens if you have arm amputations. And what he found was that you could actually map, in some upper arm amputees, sort of clear images of the digits when you touch the face. And so, and then he also noticed sort of that you could also map out sort of a clear image of like the hand on the shoulder in a telescoped position. So that was clear evidence that in humans, sort of what you're seeing in non-human primate evidence, you can also get in human amputees. And so one of his patients who he treated had a phantom itch. So how do you scratch an itch in a part of the body that's no longer there? Well, in his case, he was able to scratch the face and actually treat the itch in the hand. So there's clearly sort of clinical applications. He said, in his small group of amputees that he worked with, that about a third of them had a clear map of the hand onto the face. So now, with lower extremity amputation, I will get the small audience that we have here today. I want to ask you a question. So how do you think that this might show up in leg amputees? Any evidence that they may have evidence of neuroplasticity? Anybody care to take a guess? Pardon?
Everything we do will cause a change in the brain, isn't it? So, and if
Right.
if that's a definition of plasticity, then listening to this talk is changing my brain.
That's true. So one of the common things that we saw, so if you have the leg, right, and you amputate it, what's next to the leg if you look at the homunculus, right? So what's near it? Well, there's the abdomen, or there's the private parts, as my kids like to talk about. So it turns out that when you really query your lower limb amputee, two of the most common things that we found talking to our patients at Walter Reed were that urination, and since most of these were males, would bring out phantom pain, or sexual activity. So one poor guy who had enrolled in our mirror therapy trial, early on he told us a story that he and his wife had marital relations. It was the first time after injury, and at the time of ejaculation, it triggered a severe amount of phantom limb pain, and so he broke down crying, and you can imagine how his poor wife felt. And so we explained it to them as to what the theory of neuroplasticity was, and they had a much better understanding of what was actually going on, and they didn't, because they were worried that they had done something wrong, and was this going to persist, and this obviously would affect their marriage. So we were able to help them in that regard. So in terms of treatments, so we decided to look at mirror therapy because none of the pharmacological things we were doing were working. And so we dug out Ramachandran's original paper, and his original paper didn't give much in the way of details. He just said, he created this mirror box, people tried it out, and after a few weeks of daily therapy, it worked, and in fact, one person, the phantom pain went away right away. And so we tried this, and we could not get this to work initially. And it turns out that there's several things you have to do, and we'll talk about what those things are. But basically, we said, what's actually going on? Can we design a trial to set it up? So we said, there's three components. Ramachandran said, you have to look in the mirror, you have to move your intact limb, and then something happens to your phantom. It turns out that you actually have to move the phantom at the same time as the intact limb while you're looking in the mirror, and you have to start with slow movements before you can speed things up. And it turns out that the instantaneous treatment was probably a rare phenomenon. So these were all things that we discovered after talking to Ramachandran, as well as trying it ourselves. So we set it up so that we would treat people 15 minutes a day, 5 days a week for 4 weeks, track pain with just a simple visual analog scale. And then we said, if we can figure out which of the components may be modulating pain, what do we do? So the primary outcome was looking at the mirror. So we crossed over the covered mirror where we covered it with a sheet. And so you're moving the intact foot at the phantom, or just mental visualization where you're closing your eyes, moving the phantom around. And so we then ran into trouble of how do we build a mirror box? And then we said, it's actually not the box that matters, it's the mirror. So all you really need is a cheap mirror, and I will say I have no stock in any companies that make $5 mirrors. In fact, we got this from a company that went bankrupt. So I guess they should have charged more for their mirrors. So what we ended up finding was that people in the mirror group actually had a decrease in pain fairly quickly. So after about a week, we could actually start seeing an effect. People in the covered mirror really, didn't change much, and when they switched over to the mirror, their pain levels went down. And then, so these are N of 6, a very small sample, but 2 of the people in the mental visualization group actually had much worse pain. And so when you think about theory number 2, this whole idea of proprioception and vision dissociation, what's mental visualization? We're actually making that situation worse. We're having them close their eyes and forcibly trying to move this phantom foot around. So we're actually making that dissociation component even greater. So that may explain phantom pain in some people. So that was evidence supportive of that. So we found that most people on our mirror groups, even when they crossed over, improved. And at 2 years afterwards, we found that it rarely recurred. So we felt that, you know, if they had a good response, it was curative. And a couple of people did report, you know, like the pain went away, and then a few months later came back. They pulled the mirror back out of the closet, tried it again for 4 weeks, and then it went away for good. So we're fairly comfortable in saying that, you know, there's something going on. We think that vision is modulating this response in at least the people who are treated and get a benefit from the mirror therapy. I won't show the data, but we actually went back and later looked, saying that and saw that people who had less pain needed fewer treatment sessions to get a response. People who started out in more severe pain actually needed more time to before you could say that the treatment was futile if it wasn't going to work. So it works for a lot of people, I think. It doesn't work for everyone. So we followed this up, building upon work Herta Fleur and her group did to look at fMRI to see what was actually going on in the brain. And so, again, we started with the cortical reorganization theory, looking at phantom pain and reverse sensations, went with this whole idea of, you know, if there's neuromodulation or reorganization going on in the foot, perhaps we could restore the original homunculus in terms of the interplay between the various regions of the brain with the mirror therapy. And so this was work that we did with Chris Baker's group at the NIH. We scanned people before their mirror therapy, 2 weeks into the session, and then again at 2 weeks later. So what we did initially was we presented them visual stimuli of hands and feet, because anatomically there's regions that you can localize and you make sure you're looking at the right region. And then we tracked, you know, what happened with therapy over time, and it's not really like a straight line down. It really sort of fluctuates. So some days are better, some days are worse. That's sort of the typical patient experience. So I'll present sort of an example of 2 people who had amputation and non-amputation. So basically the amputee had a left foot amputated. So we showed them a static image. So the control, you can see there's not much activity. So with these heat maps, red is more activity, blue is less activity. So what we found in our amputee was that in the contralateral hemisphere, somatomotor regions actually are more active, and it goes away with mirror therapy. And then on the contralateral side, sort of seeing the static image wasn't triggering anything. And so we found that really it was specific to an image of which foot was actually amputated, but not the contralateral foot nor the hands, which were intact in these individuals. So we think that there may be a marker of excessive activity that is somehow triggered when you see this picture of the limb. And so our feeling is that somehow mirror therapy must be modulating the system over time and restoring the original balance. So we followed that up since that time with sensations, looking at changes in positioning of the phantom limb. And so we went back to Ramachandran's idea of, in terms of reports of hand-to-face remapping. And so we said, well, what happens if you start changing the position of the phantom hand around? Does that actually change the map of the hand on the face? And Ramachandran had reported a case report saying that he thought that this was going on. And so we talked with him, and we went to the Amputee Coalition meeting and recruited upper extremity amputees. And so we basically did careful maps to try to see, you know, where we could find fingers on the face, and what would happen if we tried to move things around by the amputee trying to do it, and then we augmented it with mirror therapy, or using the mirror. And so basically we mapped people's faces to try to determine if we could feel the hand on the face sort of in different positions. So we had the hand palm up, palm down, extension, and then flexion. So it's, I guess, well, I'm not doing the Macarena here, but basically we were trying to get them to move things into extreme positions so that we could actually detect if there was any changes. And then we also asked about phantom pain changes. And so we were able to recruit 16 people. 12 of them had a history of phantom limb sensation, and 9 had experienced phantom pain at some point after their amputation, though not everyone at the time we recruited them had it. And so we found that 11 of the 16, we could actually map a hand sensation onto the face. There wasn't actually any consistent pattern of hand mapping onto the face. So it wasn't like it was a consistent anatomical change that if you were going to detect it, you'd find in the same specific area of the face each time. That would have been nice, because then you can actually design more experiments to look at what's going on. And then no one arm position was actually unique in the changes of the sensations that were felt on the face. And interestingly enough, we had 2 congenital amputees where we could also detect phantom limb sensation. So even though they never had it before, after we worked with them and mapped them, it turned out that they actually could have hand sensation. So we're not quite sure what that says maybe about the congenital loss. So with congenital amputees, the thinking is either it's a lack of development of the hand in this particular case, or they lose it because of something called amniotic band. So the amniotic cord wraps around the limb, it causes ischemia, and then the limb basically is resorbed during development. So it's possible, that you have cortical development, and then if you lose it that way, maybe that's what's going on with this residual pattern of the cortical limb. And so we found that actually changing the location actually shifted the map on the face, and with mirror therapy, we could also sort of enhance it. Similarly, we also had a situation where tactile stimulation of both the left and the right face, so contralateral and ipsilateral to the amputation, it actually, when the person was wearing his prosthesis, it actually caused his wrist, it was a motorized thing, to start spinning in a circle. So there's evidence of transcallosal signaling. So somehow what's going on, we think, is that these phenomena are fairly rapid in shifting. It's not like taking more than a few seconds to reposition your hand, your phantom, and then we're actually able to detect changes. So it suggests that part of the phenomenon is that it's some level of either like unmasking of dormant synapses, or like a shifting pattern of like regional interconnectivity that's being brought out. So there's some sort of peripheral nervous system feedback into the central nervous system in real time that's being reacted to very rapidly. And then lastly, we've also looked at phantom limb pain characteristics, because different people report different things. So everything is called phantom limb pain, right? So but you could have cramping causing it, or it could be electric, shock-like sensations. And so the last major study looking at sort of phantom limb pain characteristics was from the US-Vietnam War, where they had a lot of amputees. And so we've been recruiting for another study, and so we looked at characteristics of phantom limb pain in about 650 amputees. We adapted a survey that's been used to try to characterize neuropathic pain, and explored what sort of modeling might, how many factors might actually make a difference in terms of how to cluster symptoms. So the age group between those with and without phantom pain in the last 24 hours was essentially the same, but it was statistically significantly different given sort of, the large numbers that we had. We had both upper limb, single and multiple limbs. And then we looked at people with and without phantom limb pain, as well as other comorbid conditions like cardiovascular disease, PTSD, depression, so the mental health things that also can come from combat or other injuries that lead to amputation. And so the characteristics we looked at were sort of the burning, squeezing, electric shock, pins and needles. We also looked at sort of any sort of residual limb triggers that could be induced, and then this whole idea of cramping. So modeling with different factors, it turns out that between 3 and 6 factors, this is an asymptotic curve, this sort of accounts for the majority of these type of symptoms. So we settled on a 5-factor model, and it turns out that the clusters that we found were burning, squeezing, and pressure tended to run together in terms of what people reported: pins and needles and tingling, sort of throbbing, aching, and cramping, and then sort of the superficial residual limb phenomenon, and then electric shock and stabbing sensations ran together. So we think that there's probably 5 major types of phantom limb pain that cluster. And then we also looked at sort of like, well, do people report just like one factor, or is it more than one factor? And it turns out that There are some people who literally just have one, but the majority of people actually seem to have multiple factors, and it seems to really cluster around 4 and 5. So people generally tend to have like electric shocks and cramping and throbbing, with or without sort of like this pins and needles. So about 50% of the people have sort of multiple things that are going on. And so we think that there's probably different etiologies. I don't think it's all the same thing, right? Because when you think about pins and needles, it doesn't seem to really go with like, why is it frozen? I can't move it. Like that doesn't anatomically or physiologically make sense. But it's possible sort of like this whole gamut of experiences is sort of being activated when you get phantom limb pain. And then looking at correlation, PTSD correlated with certain factors, depression with others, but the factor scores were not related to the cause of the amputation. So whether it was trauma or cancer or diabetes or vascular things, there sort of wasn't no predictive sort of outcome in terms of trying to figure out what was being generated or would arise after you had an amputation. And then anxiety and baseline neuropathic pain also had no correlates. So our interpretation is we think that 5 factors is probably the best model to use when looking at phantom limb pain. And then sort of the open question that is sort of to be answered is there a difference if you start treating some of the mental health sequelae of your amputation, like when you intervene with sort of a comprehensive rehabilitation program, would that affect, your mental health symptoms if you took away your pain, or vice versa, that if you took away the pain, maybe you could also affect sort of their response to treatment for their mental health sequelae. This work has been done over the last 15 years by many of my colleagues and research assistants who've worked on the projects over the years. And then the funding has come from the military, the Dana Foundation, and then the NIH. So at this point, let me open it up for any questions the audience may have.
So thank you for this presentation, Professor Tsao, and we have several questions for you. So the first question is if visual feedback, if visual input can affect the presence of phantom limb pain, is there a difference in occurrence of phantom limb pain in amputees with visual impairment?
So that is a great question. We have never been able to find a blind amputee to actually figure out if that actually makes a difference. So we are still looking.
Okay, thank you. The second question is, are there specific types of phantom limb pain that are most addressable by myotherapy?
So we believe that sort of the cramping phenomenon probably is one of the most amenable to treatment. So so the key is to start with slow movements, and if you're able to get captures, we call it, with sort of visual capture of the phantom, we think that sort of over time you can actually get good movements. And what I didn't talk about was 2 other things, was that with telescoping, one group reported that it was less amenable to treatment with mirror therapy. What we found, though, was we could actually rebuild the normal length of the limb over time with mirror therapy, and we could treat phantom pain. And then in a couple of people, we actually stopped the mirror therapy after they got better, and they said that the telescoping went back, sort of, it returned, but there wasn't accompanied by pain. So like, in our mapping study, we found sort of instantaneous change. So we basically rebuilt this guy's arm with the mirror, and as soon as he finished his study, he said, hey, my arm literally just felt like it was shrinking back, like he could feel it shrinking. So it was this weird sensation that he reported. So somehow, there's something else going on in instant, real time that's detectable.
Okay, thank you. So we have a question from Professor Mackin, who is following us online. For your first sensation study, did you have any control condition or participants? If not, how do you know that the reports are reliable and related to the amputation?
So the controls sort of are normal individuals who did not have amputation, and they did not have any referred sensation. And then we had another group which we excluded, which was people who we could not map referred sensations onto their face at all. And when we asked them to sort of try to move the hand around, they really had nothing that we could detect. So that's why we sort of focused on only those we could actually get a map.
Okay, thank you. Then we have a statement followed up by a question by Professor Bensmeier. John Cass and Niraj Jain, I hope I pronounced it correctly, show that the reorganization observed in the cortex reflects changing in the brainstem, specifically projection from the trigeminal nucleus and to the cuneate nucleus are potentiated and cause a new pathway from face to hand representation. Furthermore, there is no change in the connectivity patterns in the somatosensory cortex. How does that fit into the brain plasticity hypothesis of pantolin pain?
So I think there's two things going on. One is sort of chronically there may be new connections being made, sort of like actual regrowth and permanent establishment of connections. I think sort of what we're seeing in these phenomenon are real-time dynamic changes. So even though the pathways themselves may be intact, there may be other pathways that are either being activated or reactivated, or something with the amputation causes withdrawal of synaptic, inhibition. And so that's why we're seeing this extra activation pattern in the absence of an anatomical, pathway change. We think that maybe a functional pathway, or connectivity pathways have changed.
Okay, thank you. Then we have a question here. Do you have experience using mirror therapy early after amputation in the age fragile patients?
In the which patients?
Age and fragile patients. So
Age.
Elderly.
Oh, elderly. So Ramachandran's original study, he looked at people sort of 10 years, 15 years out and could treat their phantom pain. So it turns out about 50% of people have this chronic, severe pain lasting decades. Obviously, the sooner you treat, the better. So we don't think that it really matters if you're a child or if you're an elderly person. The key is if it's going to work, try to get it into them sooner. And so physical therapy, even in the hospital, like we started with some of our soldiers in the hospital and took it to the bedside, and we could actually treat them. So I think that it's sort of what is convenient for the patient and the family is critical in terms of designing the rehabilitation program.
I have a question myself. Did you standardize the instructions during mirror therapy?
So we actually told people very specifically what to do, which is, this is how you want to set up the mirror, sort of either sort of in front of you upright if you're an arm amputee, or sort of you can be seated and tilt the mirror so that you can't actually see the phantom at all. So we actually augmented tried to force them to actually look in the mirror to actually get to see the reflected image, and try to cover up sort of the phantom so that you don't actually see it. And then we said very clearly to them, start very slowly, try to move as much as you can in terms of the full range of motion, because early on it turns out that many people are stuck, so they don't have the full range of motion anymore, and it's over time they're able to rebuild it. Sort of like, if your muscle, like a frozen shoulder, for example, like if you can't move it, you don't suddenly try to lift it, you want to sort of gradually remobilize it. And then to start slow and make sure you can get visual capture. If it doesn't work, wait and try again tomorrow, and do it every day for a few days to see if you're going to so you can actually get movements. So
the contralateral was always matching the position of their phantom.
Right. So, and of course, sometimes people are in this weird non-anatomic position. They couldn't match it. So we said, try to get it as close as possible to matching.
Okay. Thank you. Thank you.
Yes, of course.
Meeting, so I apologize for that. But I'm interested in this John Koss Niraj Jain result, because it seems relevant and maybe underappreciated. And one other thing that he did that I think the linchpin of the whole thing is he deafferented the hand representation in monkeys, and then waited for this aberrant face activation of the hand representation in somatosensory cortex, and then he inactivated the cuneate nucleus, right? And then suddenly that aberrant activity in hand representation disappears, right? So not only is there no structural differences in somatosensory cortex, but you can completely abolish all that activity just by, inactivating the cuneate nucleus, which itself is no longer afferented by the hand. So it seems like it's not just, all this stuff is happening in the brainstem, according to this result, which I don't know, it seems interesting and relevant.
Yeah, so that's a great point. I actually think that there's probably several, way stations sort of in the pathway, right? Because you think about sort of the peripheral nerve. So it turns out if you do like a brachial plexus or a lumbar plexus block, right, you can actually stop phantom pain temporarily in some individuals. Certainly, if you look at the spinal cord literature, it suggests that spinal cord injury patients, some of them have phantom sensations. And then this animal work sort of with these other relay stations, I think all along the way there are different pathways where you could potentially intervene and actually change the outcome. I mean, obviously, sort of from a sensation standpoint, it's the cortex finally is the ultimate, you know, place where people are actually experiencing something. But I think that there's probably anatomical, you know, pathways along the way where you could potentially intervene to affect the whole experience.
Great. Thank you very much. We have a lot more questions, which I'm actually happy. So we're gonna save those for the panel discussion. I have my own take on, on some of these things.
Sure.
So we'll go through the lectures and later in the panel discussion, then we can have a more real-time kind of debate on these things.